Mic on. Okay. I'm going to go ahead and call the meeting to order at 6:32. Clerk, can I get a roll call?
Beginning roll call now. Rebecca Carabes. Marco Durazo. Michael Fisher.
Here.
Alexis Lewis.
Here.
William McClure.
Here.
Shirley Melnico.
Present.
Kalima Salahuddin.
Here.
Robert Solano.
Here.
And James Simmons.
Here.
Thank you.
Okay, the next item is our public comment period. Everyone is limited to 2 minutes. Do you guys need a little moment to get the first speaker? Okay, 1 second. If we can't fix it, it's okay. We can live with we could live with it. Technology.
Okay. Okay, we will now move on to agenda item number 2, general public comment. This item is reserved for persons wishing to address the Independent Civilian Advisory Commission on a topic within the jurisdiction of the commission, but that is not on the agenda. Public comments on matters on the agenda shall be heard at the time of the matter is called. Please fill out a speaker slip. And please note, the commission may not discuss or take action on items not on the agenda. Please note we received one number of written comments received prior to the meeting. They were shared to the commissioners and posted to the Independent Civilian Advisory Commission website at smcgov.org/ICAC. We do have one speaker slip. I'd like to call Jim Lawrence to the podium.
Good evening. First of all, let me thank you, Commission members, for volunteering. Certainly appreciate you stepping forward in this effort. As you know, I'm the board chair of Fixing San Mateo County. We did release a public statement today regarding the matter going on in the sheriff's office, so I won't read that back to you. I would like to say, though, that Fixing San Mateo County calls on the Board of Supervisors to establish a civilian oversight board and inspector general as a lasting solution for promoting fairness, transparency, and accountability in law enforcement across San Mateo County. Thank you.
Thank you, Jim. We have no other public speaker slips. Last call for public comment. Okay, we will now move on to public comment on Zoom. I'd like to call Pat. Please begin when you are ready.
Hi, I'd like to second Jim's comment about, being grateful that the commission was formed, and to all of you. I also want to give a quick suggestion to whoever runs the website for the commission and the agenda information. Can someone put some time in and put the current meeting information at the top of the page, and then move past meeting agendas, et cetera, to another page that you can link to, so that we don't have to scroll down 2 feet of information to get to the current meeting. As far as the recent newspaper articles, I would like to say that I spoke last week about fearing retribution from the sheriff's office for trying to file a complaint, and I can't file it because I don't know who the sheriffs involved are. And apparently in the paper this morning or yesterday was the fact that someone in the sheriff's office bailed at the last meeting from a press conference because she was afraid of retribution from her fellow officers. There's an expression in Hebrew, kol v'homer. It means all the more so. If a sheriff in the department is afraid to say anything against the sheriffs in the department, all the more so a disenfranchised, low-income resident of the community is terrified of speaking up against the sheriffs. So I really hope that this commission stays on point, stays independent, and takes the citizens' concerns into account. And I hope that at some point you guys have to get to have a conversation with Ladoris Cordell, and that instead of whatever the word is, muffling you, that she amplifies whatever point of view you've come to by the time you come to it, because I assume she won't have an opinion by the end of, by the time you have your private retreat and do your year-long plan. Sorry, that was garbled. It's been a long day. I hope everybody understands what I just said, and I'm done. Bye.
Thank you. We will now move on to caller ending in 562. You may begin when you're ready.
Good evening. Thank you very much, commissioners, for your time and your volunteers. We really appreciate it. Like the two other previous callers, I'm concerned about the independent investigation. My name is Caroline Vertongen. I have a long draft list of failing to protect people's lives and property. So may I remind you that the San Mateo County Sheriff's Office is dedicated to protecting lives and property and is committed to provide the highest level of professional law enforcement and correctional services. I have not seen that for at least the last 12 years. And we have addressed all the issues with all ranks of law enforcement. At this point, I don't know. In 2019, Sheriff Bolanos listed the policy, was the sheriff's policy and manual. I hope you can look at that. When we started addressing the allegations, we went by the Constitution and by the California State Government Code, that all we got is one runaround to the other runaround. So hopefully you guys will give us some time where we can explain what happened before and what we continue to see nowadays, because we have not seen an improvement, and I really hope that you can change that. But you need all the information, and 2 minutes or 3 minutes will not do it. So give us a chance to educate you what has failed, and let us present it to you. So thank you.
Thank you. Last call for public comment on Zoom. We have no more hands raised.
Thank you. Moving on to the agenda, can I get a motion to approve unless anyone has any changes?
So moved.
All those in favor say aye. Aye. Okay, so we're going to move on now to a presentation on programming, the reentry services and correctional health. So I'll turn it over to the Sheriff's Office.
Good evening. Thank you. My name is Melissa Wagner, and I'm the Sheriff's Office Program Services Manager. I'm in the Corrections Division, and I oversee jail programming and reentry for both correctional facilities. I know that many of you are touring both jails next week or very soon, and will be able to look and ask questions about the operations. Tonight is just programming and reentry, and next week, if you have any tie-in questions for that, you can just let the sheriff's personnel know, and I'll bring those answers back to you. Okay, so tonight I'm going to be speaking about the Aspire jail programs. If we can go to the next slide. I'm going to spend a moment on this slide just to make sure that you have an understanding of, in a sense, the paradigm in which we think of programs and services. And might I add, the presenters after me will also be talking about forensic mental health programs and substance use disorder programs, which includes the detox program. So that will be following. Okay, so when the jail was being planned, there was a strategic implementation plan group, there were focus groups, et cetera, listening to the community members, listening to other stakeholders, and really the focus was on what do we want to bring to the new jail, which had more program space, and what can we do in McGuire, which has less program space. And really what we came down to when it came to name something, because we always have to name something in government, is ASPIRE. And ASPIRE stands for Access to Services and Programs to Inspire Reentry and Empowerment. It is a mouthful. It took me a lot to memorize that when I first came over here. But really, my favorite part of the ASPIRE model is the first two words, and that is access to. If incarcerated men and women have no access to any programs or services, that is not what we want to do as a county. If they choose not to engage or to just engage a small bit, that is their choice. But as public servants, it's our responsibility to make sure we have a model in place so that they have these programs and the services that they can access during their period of incarceration. So I want to keep that in mind as we look at this high level of programs and reentry. We can go on. Okay, so essentially, the ASPIRE program is in the Program Services Bureau, which is a unit of corrections. It's a unit of the jail. And it is composed of essentially four main areas: conducting assessments, doing case management, targeted programming, and reentry plans. We're going to go into each of these throughout the slides, so we can move on from this particular slide. Okay. So we have these areas, we have our goals and objectives. So how do we create our work to meet these goals? First, we identify programs at all different times, right? We bring on new programs as we seek them out, as they find us. So that's an ongoing iterative process of bringing them on board. We focus on a tight continuum of care. Now, this is really important, and this really is the outcome of actually about 18 months that we engaged with the County Executive Office back starting in 2016. Around that time, the county's focus on supporting programs and services in custody as well as out of custody really showed us as a county that we were coming out of a phase in government where things were siloed, right? Laws and policies in a variety of different departments were such that everybody seemed to operate independently. Now, the thing is, the work that we do for the justice involved, it cannot be siloed, right? The population needs different things from all different parts of our county system. So we spent about 1.5 years and identified the different locations in our work where we were duplicating efforts. This would be efforts, this would be sometimes even in the budget, and unintentionally, we'd be working at cross purposes. So when we engaged in this work, we were able to identify and put in place new processes, new procedures, so that at the very least 5 counties, or pardon me, 5 departments that really focus on the justice involved both in custody and out of custody could work really as close as possible to a very tight continuum of care. And that includes also the communication and the interaction among the professionals in the county on behalf of the client. And then finally, really making sure that each department really was aware of what the other departments did, that we knew the community-based organizations that worked in this space, primarily in our county, but in our neighboring counties as well. So the tight continuum of care, we'll see a little bit later in the presentation. Next slide, please. Okay. So with my partners in Correctional Health, as I mentioned, they'll be going over the medical care and the mental health care in the correctional facilities. And with the Sheriff's Office and Correctional Health, those are the 2 entities that provide services in custody. So together, we focus on our work and making sure we are able to do all we can so that when the men and women are released from custody, we can, whenever possible, hand them off to that next service provider who can take up the next tasks. And obviously the benefit is clear, is that if we are working together in a coordinated way, and if our energy is such that we tinker with that where we do see problems, we fix that in our agencies so that the clients don't have a negative outcome to the extent that we can prevent that. So every day, all the different units within Correctional Health and the Sheriff's Office work together for the clients, the incarcerated population. When we do their reentry planning and we're communicating with the incarcerated person, we're also working with the other departments in this space. So we, in our county, have Human Services and Behavioral Health and Recovery. We also have Service Connect, and for those of you who are familiar with Service Connect, that is the county-funded reentry program. It is a partnership between the Human Services Agency and Behavioral Health. But as my colleagues will discuss in their next presentation, BHRS has so many other programs that serve the justice-involved population. Certainly probation is our partner, and a variety of other program providers in this space, including Five Keys High School. We can move on. When we look at the categories of programs that fall under Aspire, they really mirror the categories across the nation. When we look at National Institute of Corrections and the main categories of programs to be able to offer the justice involved, they fall generally into cognitive programs. I separate out substance abuse because it's a very specialized part of cognitive programs that my colleague Holvis will address next. And then we have education and literacy, vocational programs. We have activities, which we also include in that, wellness, and then religion. Religion is not a program. It is constitutionally protected, but we put it up here because of its prominence in the scheduling for the IPs. Next slide, please. Okay. So you'll see on this chart that we track the total number of seats filled for programming, and we start this in 2016-17 because that is the year that Maple Street Correctional Center opened. We opened in March of 2016. with a few housing units, and then we started filling up the different housing units and onboarding programs in a very measured way as the population increased. So over time, the total number of program seats has trended upwards. You'll notice, of course, everybody's favorite fiscal year, 2021, when COVID hit. We had one of our highest years up to that point was the previous fiscal year, 1920, where we closed programs on March 12th at about 12:30. Everybody left, and we were shut down. We're very proud as an agency to have been able to launch virtual programming July 1 and have programming available during the entire COVID pandemic. We had 50% fewer inmates, but we were able to offer programs in both facilities. Because it was an opportunity to bring in technology, which we would not have had in the jail before. I mean, Zoom and a laptop you would have been walked out. But we were able to also onboard new programs during that time, which was huge for the incarcerated population due to, we forget, but it was masking. It was very specific housing. It was, if you're somebody in your own pod had COVID, that would, perhaps have you have to sit out your programs because we were monitoring and quarantining people to prevent the spread inside the facility. So we're very proud that we were able to continue offering the men and women opportunities to engage. This chart has the total number of program seats, but what we know is that about a third of the seats filled each year are by men and women who are participating in more than one program, right? And that's really huge when you look at the engagement by the men and women. We can go on to the next slide. So here I'm going to talk for a moment about the in-custody case management. As my colleague Karina will discuss in a moment, she and her colleagues offer the forensic mental health case management. So that's very specialized, and it's different than the in-custody case managers in the sheriff's office, who are not clinicians. So we'll hear about those programs in a moment. During the time somebody is incarcerated, we're interacting with them the whole time from about 30 days up. Certain things happen once somebody is sentenced, though. The biggest thing is we have the only known variable, which is their release date. So although we are working with them during their time unsentenced, when they hit 90 days, prior to their release date, the focus of the in-custody case managers moves to release planning. They assess for the county-funded reentry program, Service Connect, and look to see if that incarcerated person is qualified. During the time they are in custody and sentenced, some have quite a bit of time left to serve. So they do then start meeting more regularly with their assigned case manager. During the reentry process, the in-custody case managers are communicating with the partners that I mentioned on previous slides. So we will be communicating in-house with our colleagues at Correctional Health. We will be speaking with the Reentry Program Service Connect, drug treatment providers, and depending on a particular person's situation, if they are for example, from San Francisco, and they are still open to a case manager in a program up there, we will also make sure that we're keeping that person posted. I bring up San Francisco because our out-of-county population in the jail holds steady at about 50%. That is a very large number. It also adds a bit of a challenge when you are doing reentry work. Of the ones that are out of county, most are in the close-in counties, San Francisco, Santa Clara, Alameda. So we are able to, they certainly don't qualify for the county program, but the case managers are able to do some work to make sure that they are connected and they have linkages once they're released. We can go to the next slide. I pretty much covered all of this, but I do want to emphasize that as you go through these next several weeks, and at least on the corrections side, touring the jail, hearing from Captain Fogarty and operations, keep in mind all these pieces, because although the program services team are non-sworn, they're civilian professionals. All of our work is done side by side, the classification detectives and the correctional officers together in each facility to make this possible. Okay, next slide, please. I mentioned Unified Reentry Service Connect. Since it's government, we use these two words interchangeably, but that is confusing when you are first presented it. Unified reentry really is a concept that we adopted back when the board formally started funding this program. And it is just that, it's unified, right? So we bring in everyone who does qualify, and the key qualifications are county residency, and then men and women have to, in their assessment, when they're assessed, have a score that places them in a medium to high risk to reoffend category. And you can't have any out-of-county holds. I'm going to talk about this for a minute, because it does matter when we hear about what happens to people when they are not released in our own county. A lot of people might have to go to another county to continue criminal justice business in another county. And then once they're done there, they come back to their county of residence. It doesn't mean that they are not they do not qualify. It just means that the probation department handles the referral because they're already out of custody. So someone doesn't lose that chance. It is just deferred while they are in another county. They come back, probation puts in that referral, and they're able to go continue with the team up at Service Connect. When Service Connect first launched in October of 2011, it did so as a program that was created in response to public safety realignment at that time. It was a very huge change in criminal justice policy in the state. So you had to fall under that umbrella. But with the success of the program and what we saw in the county with the benefit of having a reentry program for county residents, the county executive office opened up the qualification so that if you were completing a sentence and you were a county resident and you met those other standards, you also could go continue receiving services up at Corey Road in San Carlos. So when you hear Service Connect or Unified Reentry, that is our county's supported program. Next slide, please. Okay. I mentioned before the in-custody case managers. So most of the time, the men and women will be meeting with more than one professional in the jail because they have more than one need. So this particular chart refers only to the percentage that are working with the civilian staff in the sheriff's office. It could also be the case, and is likely the case, that they are also working with the substance use disorder program with forensic mental health specialists. Nonetheless, from 14 forward, 2 years before the opening of the facility, we began working with the incarcerated population at McGuire and at the old women's jail and transitional facility. And the engagement of the incarcerated population trended up over time. And we look at this as engagement in full case management services, working with them to go over the programs they're eligible for while they're incarcerated, getting them into those programs, encouraging those that may not have started programming, and also encouraging those who might have returned to custody, and sometimes they, believe it or not, they can be embarrassed to enroll in programs again because people see that they've come back and they don't like that. They see that as a form of failure when we want them to be able to lean back in, enroll again in high school, and to continue the work that they're doing. To all their different needs that they have while they're incarcerated. And next slide, please. Now here is the term we use that just represents the way in which we work with our partners in the jail, Correctional Health. So as I mentioned previously, many of the men and women need professionals from both sides, right? They need the sheriff's office, they need substance use disorder counselor, mental health counselors. And so when we have men and women who fall into this area, we just call it coordinated services. It's not a creative title. This is just when we coordinate with our partners in Correctional Health, and they reach out, we reach out to make sure that the men and women have whatever it is that they need while they're in custody, but most especially as they're preparing for reentry. If somebody is active to a substance use disorder counselor or a forensic mental health clinician, my team only does the assessment for reentry services, because after that, we don't provide those needs. The needs are provided by Correctional Health. So together, we need to get that person ready to be released and to hand them off to the next professional. Next slide, please. This is in your packet, I believe. Nonetheless, this is just an appendix of the different programs that we have broken into the categories that I mentioned before. And I'm just going to do a quick check. Do you have the copies of this presentation? Okay. Well, they'll be made available to you so that you will be able to look at them at a different time. And certainly any questions you have, you can submit them, and the Sheriff's Office will respond. So as I mentioned earlier, the categories is cognitive. We split that into substance use disorder. So you'll see Correctional Health is going to be presenting on their substance use disorder program. Education, we're very fortunate in our county to have Five Keys High School. Five Keys High School is a fully accredited California high school that offers its graduates a full high school diploma. This is very significant because in California, a GED is really not what it used to be, right? What is special about the way Five Keys has developed its program is it was developed within the San Francisco jails. So that is where it was birthed, so to speak. And when our jail opened in 2016, we onboarded them at the start of the 2016 academic year in July. We were the 4th county in California to launch with 5 Keys, and it has been a very successful partnership ever since. What is really nice about the model that 5 Keys developed is that, one, if an incarcerated person has a GED, they can roll all of those credits forward and then work on those final credits in order to earn the diploma. And second, and perhaps most important, is they cannot control when they're going to be released, right? So what 5 Keys did is any county they go into, they have at least one community site. And anybody can enroll in the community site. You do not have to have recently been incarcerated. And what this does is allows the men and women upon release to continue high school. And they can go to any 5 Keys in the state. I can't remember off the top of my head how many counties 5 Keys is in now, but it's up there. So, and in fact, in San Francisco, I think there's like 5 community sites for 5 Keys. So it really is a game changer for the men and women. Any questions on this before we segue into the forensic mental health and the substance use, and then all of the medical services that Michael will go over? Yes, ma'am.
Thank you. I did have a couple of questions, and do you have demographics of who's receiving the services? And
Yeah, I can get that for you.
And also languages spoken. Are these in different languages?
We do have the conflict resolution and anger management. We have that in Spanish as well. And I want to say, and then ESL. So we don't have any other languages other than Spanish, though. The Enneagram Prison Project has all of its materials, its book and its workbook in Spanish. And if any of the incarcerated people can understand English, they can participate in the class. And that is it on terms of bilingual. What is counterintuitive is there aren't many providers that our partners can find to do the programs in Spanish. I bring that up as counterintuitive because I was a bit, floored by that. So we try.
Yeah.
Yeah.
And I also had a clarifying question.
Yeah.
So I wanted to understand a little bit better about the out-of-county. 50% of all people incarcerated are from out of the county.
That is correct.
Maybe.
And that's held steady for many, many years. When they are arrested here, if charges will be brought, they remain, if they are not eligible to post bail or they are unable to post bail, they will be here pre-trial throughout the course of their proceedings. And so that has held steady since pretty much the whole time the new jail has been open. And I say that because when we screen everybody for Service Connect, the first thing that disqualifies a person is county residence.
So the thing I'd just like to ask is if you could provide us with numbers.
Mm-hmm.
Yeah, thank you.
Okay, thanks. Go ahead, Rob.
Thank you. What happens if an incarcerated individual refuses your services?
Nothing. They're perfectly welcome to not engage. They do not have to.
Okay, and I have one more.
Mm.
What type of assessment tool do you use
In
order to
yeah.
assess them for your different programs you have?
So for the county-funded reentry program, we use ORIS. It's the Ohio Risk Assessment System, and that is a series. It's a variety of assessments that have been created by the University of Cincinnati Institute on Corrections, and We follow whatever tool the adult probation has chosen. And that was true when we used CASE, if you remember that, Shirley. And when they changed over to ORIS, that's what we use. So that we're both using the same tool for screening, and it also affords the same language to be used. Now that's for intake, so to speak, and preparation for reentry. There are 2 other programs that do assess. My colleague Holdis will talk about substance abuse, but the other one is for our domestic violence program. The priority for people taking that, they have to have a current charge, domestic violence. If seats are available and they have a history of those charges, they can also take that program. They are able to take a certain number of classes while incarcerated to meet their court order, and the rest has to be completed out of custody. So those are the tools that we use. And they have to not have, they cannot have a high school diploma. So that's really the only criteria, but our literacy programs are open, except for the fact if we don't have any in another language. Vocational is not any aptitude test. It is they have to be approved by our classification unit for the vocational programs, such as our culinary arts program. The culinary arts is in a full training kitchen that you will see, so they have the use of knives and other equipment. So it's a different kind of screening to approve them to go into that.
Thank you.
Yes.
Go ahead, Shirley.
Thank you, Melissa.
Yeah.
I do have a question, and that's on, you said that for Service Connect will only accept people that are high-risk offenders or moderate. So what percentage of the jail is moderate and high?
Most.
Most.
It's most. The type of offender that comes to county jail now and for quite a long time has been moderate to high. We don't see many low risk to reoffend folks any longer. That type of a California county jail is no more. Yeah.
Go ahead, Alexis.
Thank you. I just wanted to know, what size is your staff? I mean, to make this a successful program, you must have a pretty huge
They
staff.
will love you for that question.
And what is the
Yeah.
ratio of staff to incarcerated persons?
So we have 5 in-custody case managers. We have 2 legal office specialists. They're our support staff. We have 1 supervisor and me. Yeah. And I don't have a ratio for you. For those who are sentenced with and have a release date, we screen everybody. So that's where the majority of their caseload will be, the proportion of that caseload will be on the reentry side, and less of a proportion of their caseload will be for those who are unsentenced and going through the program. So yeah, it's a small but mighty team. You're welcome.
Thank you for the information. Just a couple questions. When you talk about program seats and there's different numbers, can you help me understand what that means as far as individuals that are currently
Sure.
that are utilizing? Because 3955, I get that. That's
Mhm.
seats, but how many
Mhm.
folks are actually utilizing these services?
So on that particular slide, it is held pretty constant that about 1/3 of all program seats are by men and women who are participating in multiple programs. Everybody that is represented on there, though, is doing at least one. Per program, we seat up to the fire code in classrooms. So there's no classroom that has greater than 25. And some are smaller. Obviously, the culinary kitchen has a smaller threshold of students. Some of our internal, and you'll see this next week, some of our classrooms that are inside the housing unit hold fewer than 25. So all taken together, that represents the volume. And then if you were to think of it as unduplicated number, 2/3 of that would be individuals who are just taking one class.
Okay. I guess what I'm asking is for the total number of individuals
Mhm.
that come through the facility in a given year,
Mm-hmm.
what would that number look like? And how did that compare to the number of seats? So,
A seat is fair. I will change that slide. A seat is just one person in the seat. So it's saying that that is a fully loaded number versus presenting a number that is unduplicated. So that is, if it, what, I don't remember what slide it is. I think it's maybe slide 6. If it is 2,500, it means that 2,500 seats were filled. So if Enneagram offered a program, and they program throughout the year, several classrooms of it, that is the fully loaded number of students are part of that number. So all of the programs, if we have 20 programs running, it is a count of each of you, right? So James and Shirley and et cetera. But then if I wanted to focus on those who take more than one, I would say, okay, 1/3 are really engaging, right? But at the very least, it shows the minimum that folks that are only taking one. And we're fine with one, just so we're clear, because they don't have to do anything when they're incarcerated. So we'll take people who just are engaging in one. I was pretty close. Slide 7. Yes, sir.
Thanks, Melissa. Just a question on folks that are serving state sentences in county. Are they eligible for these programs?
Absolutely.
And then are these programs all funded by the county, or is there state funding as well?
So the programs funded through Program Services Bureau is funded through realignment dollars. So it comes from the state to the county, and then the probation department works in I really don't know how they determine the money that comes to the sheriff's office, but it's determined by the adult probation department. Is that correct, Adam?
Yeah, that's correct. There
Yeah.
was when the state moved a lot of the folks out of prisons into the county jails, certain funds became available for counties to be able to deal with that. There was large, ongoing, for many years, discussions about how you allocate those funds most appropriately. And so that's sort of where the slice for some of these programs comes from. And for whatever reason, I wasn't there. Probation is the one who heads this decision on determining how much goes to each location.
But then we also have programs that are by volunteers. But all those who have a contract and are receiving funds comes from realignment dollars. But serves anybody. Yeah.
I have questions. So for this slide, I see there's 3,955 opportunities for someone to do something. What percentage of the people, how many are taking at least one thing that are incarcerated, IPs?
2/3 are taking
two-thirds are
at least one.
So there's 1/3 that are not doing anything at all.
1/3 are taking multiple.
1/3 are taking multiple, and 2/3 are taking just one. Okay.
Right. We actually don't track those that
So
are
not of those
not doing
numbers.
anything.
Yeah, or just, you don't track those that are not doing anything.
Mm-mm.
Okay.
I mean, technically we do, because we screen them for reentry program, Service Connect. But we don't have an interest in counting somebody and saying, Shirley, if I may, Shirley, Shirley is not engaging. We will say, you know what, Shirley, you're eligible for this program. You know, have you tried it, blah, blah, blah. But we won't keep a roster of people who choose not to engage.
Is there any tracking of those that don't engage to see if there's a trend of why? Like, is there a certain specific subgroup that's choosing not to engage?
I think that's a really good question, and we've never tracked it. It doesn't preclude us from doing a point-in-time study of that at maybe every quarter in a fiscal year, 2 fiscal years, to see if we notice any pattern.
And then, can we go to like the slide that had the objectives on it? It was like
Yeah, I
towards the
think
beginning.
it's, yeah.
Little, keep going, yeah,
Mhm.
yeah. Little one, this. So it says to attain our goals, these are objectives. What are the goals?
Oh, sorry, if you go to the previous slide,
The previous
3.
slide is the goals. So,
Yeah.
okay, so these are the goals.
Yeah.
And so my question are, because these aren't, like, how do you measure if you're achieving these goals?
Well, we're required to screen for Service Connect reentry program. So that is something that is measured and reported, both in our performance measures to the CEO's office, but also to probation and Service Connect program. We have the programming that is also reported in our performance narrative. We don't have a specific quota for the number of assessments we do is going to vary based on the population at any given time. So we don't have a quota on that. We like to be able to screen everybody between 30 and 90 days. Now, I'm going to add one caveat. A lot of folks who, once they're sentenced, for all of the time they were incarcerated pre-trial, all of those days count. So we have a lot of people who come back from court and their time served and they leave that very same day. This is someone who, like I said, can still be screened by probation if they live in the county. But they would not fall in, we would not be able to capture that person who leaves that day or, within 3 days of being sentenced. So we aim for 30 days. We do go as far down as 20 days when we're fully staffed. And, sometimes we have folks that we know are in the county. They're high. They use a lot of different services from a variety of departments. And so if there's communication from all our partners, we'll try and do maybe 4 days of screening to get that person referred in, to try and keep them engaged and tied to at least one person, one county agency. So that's the 30 to 90 day, but we try and go as far down as we can, depending on the staffing and the ability to do a quick turnaround.
Is there any, and this is my last question, is there any follow-up post-release to see, like, people in this particular program have less recidivism or success rates inside leading to success outside?
So we have tracked that with our vocational programs that are offered by Job Train. And that is because when they stay connected to Job Train is able to communicate with them. Once they leave our facility, we cannot contact them. And of course, we always want to know how they're doing. We don't want to necessarily find out how they're doing when they're back inside. But
Yeah.
that's the benefit of having partners who are connecting with them and staying connected to them.
Okay, so I lied when I said it was my last question. How many seats are job trained?
I'd have to look that up. It's much fewer because they do the hands-on vocational training. The seats in their work readiness, life skills, their substance use counselor, those have a higher number of people. And then in their culinary arts, it's fewer because of the resource, and not as many people qualify to go into the kitchen.
Okay.
Yeah.
Go ahead, Rebecca.
So just so I'm understanding the numbers again, whatever numbers are that you have of people that are incarcerated, then we know that half of them are not participating because they're from out of county.
They can participate in anything offered to them in the jail, regardless of county status. They are not eligible once they're released to go to the county-funded reentry program. But when they're in the jail, they can engage in programs, regardless of county. Thank you very much, yeah.
Shirley?
I just would like to know if you could get the recidivism data from Service Connect, because it's easy to get if they're coming back to our jail, to run the names through have the sheriff's department run it.
I think that we can definitely work with the CEO's office on what recidivism and a point-in-time study looks like. Yeah. It's tougher than you think, Shirley.
Okay. Any other questions? Go ahead, James.
Yeah. How often do you take a look at these goals and maybe reevaluate? Because one thing I see is to connect incarcerated persons with in-custody programs to address needs. But a little earlier, we talked about not tracking individuals who don't participate.
Who don't,
so
yeah.
how?
Yeah, so that's a bit more nuanced. It's not data-driven back to the issue that we're not tracking it. But the in-custody case managers tend to know all the people. So first of all, the men and women know the programs, they sign up for them, and they do that. But when they are, may I, Shirley, with you again? If we know that Shirley has been here before, but she is not engaging, but she has engaged in the past, if one of the case managers is working with her, maybe to get her some information she needed on a program, they always will say, hey, Shirley, why aren't you enrolling in any programs? So they know because they are in the housing units, and they tend to know what is going on with that person, and especially if they were programming before and are not when they come back. We had a gentleman who was one of the first sentenced under realignment in this county, and he was an amazing programmer, and he got himself all the way to transitional and went to job train, finished the construction program, got into the union, and it was really neat. And when he came back, he did not want to leave his cell. He did not want anybody to know he had reoffended. He felt like a failure. He also felt like he said he had a lot of shame. And so it took 3 of us to get him to enroll again in high school. But he did it. But that's a very real thing, and it's specific to the individual. The one thing we generally talk to them about is when they drop off programming. And it's generally because they have created a strategy for themselves. If it's highly likely they're going to have a prison sentence, they want to be able to receive milestone credits, and that has changed a bit. So we try and encourage them to finish high school so that they have more opportunity to do programs when they go to state prison. So sometimes they do it with their own belief of a strategy, right? And we try and get them, to relook at that they can continue programming here as well as there, depending on where they're housed. Yeah. Does that address the question?
Yeah, it was really directed more towards your operations and not the individual.
Oh, yeah.
So it wasn't really.
We
'cause
do
I
it,
definitely
yeah,
understand
for sure,
what
yeah.
you're talking about.
I mean, I think they do it during their day-to-day
Yeah.
work. They'll
Again, it's
yeah.
more,
Yeah.
people going to look at it and say you have a goal, and
Yeah.
you're not meeting that goal. You would
Yeah.
want to take a look at that. That's
Well, we actually do set our goals in our performance measures, the number of assessments each year, even though it's tied to the average daily population. We've met or exceeded that goal every year since 2014. And then with the percentage of incarcerated persons who engage with case managers, we do set that percentage at 70%. And we've met or exceeded that goal every year since we've been tracking that. So we look at that as, depending on what fiscal year it is, as a huge success, especially for COVID, especially when we have some staffing vacancies, that we're still able to meet the goals that we work with the CEO's office on, our performance measures.
Can I just briefly, the sense I'm getting from all the questions, which I'm sure you're getting as well, is that there's an interest in some information on uptake. How many folks are participating, and what's the uptake on the program offerings? I know that's complex because people cycle in and out of custody, and uptake can be impacted by a lot of things. But maybe that's something we can look at together with the CEO and the sheriff's office to understand ways to share information, and it's something that
and I think
group could dive in
because
on.
I think what I was getting at, and I wasn't using the right word, with the performance measures, I think would be good, because for these are the goals of what your like annual performance measures, it would be a good idea, because I think it would help get us a better sense of what you're doing day to day.
And we do set them with each contracted provider, not with our volunteers, although that is actually important as well. But so each of our contract providers has, we work with them each year to set the number that they want to serve, and then a percentage, off the top of my head, it's based on the students' answer on, did you learn something that will be helpful in your reentry, et cetera. That's on a contract-by-contract basis, but not at an aggregate level,
Rebecca?
So Melissa, I tried to do some numbers really quickly. With the 3,955 and 5 case managers, that's about 800 in a caseload. And that's only for people who are participating?
So that number is for programs, and the case managers, in very few exceptions, are not the ones teaching the programs. Those are all of the program providers who we bring in, either volunteers or under contract. So of the 20-plus programs that are offered, each one has several different teachers depending on the program, the type of program, and their capacity. So those two are independent of one another.
But they're all being case managed, right? If they're in a program, or does everybody get case managed?
For reentry screening, every incarcerated person that is sentenced with at least 30 to 90 days left with us does go through the screening process and the reentry planning. When they're unsentenced, they can engage in any program they want, and should they be approved for it, they can participate. And that is by whatever teacher is coming into the jail to facilitate that program. So if there's, 3,600 in a year, you just look at that at a monthly basis. That is just a high-level math, not a per program that we were talking about earlier.
So it's still around 800 in a caseload?
It's not a
case manager.
caseload, it's students
Yeah.
participating in programs, so they're very, very different.
Okay.
Yeah, they're
I
very
think it's hard to
different.
do the math program because you don't have all the numbers. I mean,
Yeah.
this makes sense to me because the school board, this is where it comes in.
Yeah.
But there's 2/3, I can't remember which thirds, but there's some that are taking multiple classes.
Right.
We don't know how many is multiple. So one person could be taking 6 classes, one could be taking 4. So it's hard to then determine how many, just from that number, how many IPs we're talking about. Does that make sense?
Mhm.
Yeah.
Mhm.
Yeah.
Well,
And
that's
what-
a whole different
Yeah, that's a
question.
whole- yeah,
So
that's-
that's a whole different question. And each year, so for
Yeah,
example, I don't have the fiscal year 23-24 performance measures up there, but the last few fiscal years, the target was to screen for Service Connect, well, for reentry, but one of them is Service Connect, 700. And we've met or exceeded that each of the last several fiscal years. So that is one metric that goes to address your question about caseload, if you will. But the programs are a whole different ballgame. So if each one of you here offered a different program in both of the facilities, you might have a classroom of 20, you might have a classroom of 10, you might have 25. And so of those, we know that there are some that are participating in more than one. That slide up there showed the number that included duplicates. So if Rebecca is taking 3 classes, you're up there 3 times. That's why the percentage was included, to show that 1/3 of folks are taking more than one. This is a high-level slide just to illustrate for you, to be able to get a sense for next week when you go, and then the follow-on information that we will work with the CEO's office and the sheriff's office to get to you. But they're 2 different things. They do go together, but they are separate.
Thank you. That was a lot of information. So
Thank
Thank you
you.
so much.
I brought a quiz. No, I'm
All
just
right,
kidding.
I'm ready. I'm ready. Yeah, you ready? Next presenter? Yeah.
Hi, good evening, everyone. My name is Michael Del Rosario. I'm the Director for Correctional Health Services for San Mateo County. Correctional Health Services, just for your information, is a division of San Mateo County Health. All right, next slide, please. Just an overview of what we're going to discuss and share with you the information we have regarding the services we offer, our mission and goal, our facilities that we serve, the partnership that we have with the Sheriff's Office, the medical services that we provide, and later on, I'll pass on the mic to my colleague Karina, who will talk about our forensic mental health program, and then later on, Holvis will discuss and share with you information regarding our substance use disorder program. And at the end, we'll show you some numbers that, some data that you might find interesting regarding who we serve and how much we spend for our patients. Next slide, please. So our mission and goal. So Correctional Health Services is a responsible health authority and provides for delivery of healthcare services for the incarcerated persons, we call them patients, in the adult facilities and youth detention facility within San Mateo County. So our goal is to provide those incarcerated within the criminal justice system a sufficient quantity and quality of healthcare services at a level equal to or greater than that available in the community. So what that means is that, we strive to do much better than what's required. We go by Title 15 minimum standards as a minimum requirement for providing services in the facility, but we try to strive and do better than what's a minimum requirement. Our patients come into our health system usually in poor health, and we address all their healthcare needs during their incarceration. Next slide, please. Just a picture of our 2 adult facilities, McGuire and Maple, which I heard you guys will be visiting, and you are welcome to, visit us in our clinic as well, so we can show you what we do. Aside from the adult facilities, Correctional Health also serves the youth population at the Juvenile Center, Youth Services Center in San Mateo. Next slide. Medical services upon arrival to the jail. So our care starts from the moment a patient comes into our facility. So we have a registered nurse that will do a medical screening on everyone. That means everybody. Everyone steps into jail, we see them first. We're the first one to assess a patient if they're acceptable for our facility. At that point, we will identify any acute or chronic illnesses that they might have. We'll screen for communicable diseases such as tuberculosis, COVID. We do a substance use history screening, and we do an initial mental health screening. So that's the first mental health screening that we do. During that time, we also do a registration. We collect race, ethnicity, insurance information, residency, which all ties into what we are trying to do in terms of creating a database. And I know you mentioned performance measures, so we're tracking that as well. And hopefully in the future, take advantage of the building that's available to us, and I'll discuss that later on. Next slide, please. Partnership of two agencies. So Correctional Health and San Mateo Sheriff's Office will work hand in hand together. So we provide the medical, mental health, dental services, all healthcare needs, and we serve the same patients. The Sheriff's Office provides for the safety, security of the patients, provides for the housing and access and provide to the patients for us to be able to take care of them. Next slide, please. This just shows you the collaboration that we've tried to accomplish this past few years, and we'll go into detail more later on regarding our behavioral health unit that we started in collaboration with the Sheriff's Office. As our substance use disorder program, we've also expanded recently. Alcal AIM Initiative. This is a new program that the state is rolling. That would allow us to build Medi-Cal in the future for some of the reentry services that we provide in our facility. And of course, our collaboration includes the communication that we have with the Sheriff's Office. We have bi-weekly meetings, regular check-ins with them. We train together in terms of the service that we provide for our staff, and we participate together in quality improvement projects to see if there's any policies or procedures we need to strengthen to build on making sure that we provide the best care we can to our patients. Next slide, please. Overview for our sick hall. What we do as part of our service. On the left, shows you the service that we provide that's provided by our doctors, our nurse practitioner. So we do acute and chronic care management, we urgent care treatment, we do history and physicals, and those are covered, Monday to Friday. And after hours, we do have the support of the emergency department at San Mateo Medical Center. We offer specialty clinics within the jail. We have a nurse midwife that does all our OB cases. She will even go to labor and delivery and help with the delivery and see our patients there if they're going to have a baby while in custody. We have an orthopedic doctor, an optometrist now that we just started. Typically in the past, we would send patients out to the county clinics to get their eye appointments. Now we bring that in our facility. So so it's much more convenient, at least for the Sheriff's Office in terms of transportation. Cardiology services, another future service we hope to implement within our system. Any specialty care that's available out there in the community, if our patient needs it, we provide it. So we partner with San Mateo County Health, so if they need the in-person clinic visit, we will send them to their specialists, endocrinology, rheumatology, infectious disease. We will send them to their county clinics. If not, we could also do telehealth visits for those patients. Next slide. Dental services available, and we have a full-time dentist on staff. They do routine dental care and exam, triage assessments, we of course dental x-rays, a lot of extractions and hygiene care. For specialty services, for oral surgery, we do have, that's available as well. If someone breaks their jaw, they need to get wired and do follow-up, or the wisdom tooth extraction, we provide it as well. Currently, that's available now in the county, dental clinic, but recently we've had this contract with a provider that would come into our facility at least once a month to take care of our very complicated cases for oral surgery. Next slide. Laboratory services is provided to all that needs it. Every female that comes into our facility, no matter your age, we do a urine pregnancy test. We do urine toxicology screening for our SUD program, our substance use disorder program. Sexually transmitted disease screening is an opt-out. So basically, we screen everybody. We offer it. Chlamydia, gonorrhea, syphilis. We offer HIV testing on a voluntary basis. Also, if it's court mandated, we'll administer it or we'll collect that. We offer Hep C testing prior to release. So we're in partnership with the county public health system, and they will come in and offer Hep C testing. And if they are identified as being positive, we'll get them connected to the county health system for further testing and treatment. Of course, routine blood glucose monitoring, we do that. Blood work, TB testing is a big thing in the jail. And of course, COVID testing. Next slide, please. Radiology services is also available, and that includes chest x-ray that we do routinely for our patients. Any routine imaging, someone sprains their ankle, they think they might have broken a bone, we schedule it in our facility so they don't have to go out to the county hospitals to get it done. We have an ultrasound machine. We use that a lot for our pregnant patients. And Panorex, full dental x-rays. Those are available at our Maple facility. And of course, EKG monitoring for just routine, someone complains of chest pain or workup for cardiac, we could do that in-house. Next slide. Health maintenance, that's just a way for us to show that the other things that we do aside from the regular day in, day out, for those who are sick, what are preventive measures that we do. So automatically everyone's assigned or gets scheduled to get a 6-month physical, and we also do an annual physical as well. Part of our public health initiative is to do an annual flu vaccination effort. So we offer it first. We offer to anyone who wants it, and we make sure that, especially the elderly, the ones with chronic illnesses, we try to sell it, make sure that they take advantage of this flu efforts, flu vaccination. COVID vaccines, we did a lot of that during the pandemic, offer that to all our patients and staff as well. Routine immunizations we do, and then of course TB testing. TB, of course, is the main thing. Anything communicable diseases, just like COVID. And where, if you're in a small setting or a congregate living situation, anything communicable is something that you would easily pass on. We want to make sure we address those. And of course, we also have dietitian consultation for special needs for our patients. If they have any special dietary needs, medical, diet orders, we have a dietitian that's available to consult with them. Next slide. All right, forensic mental health. I'll pass it on to Karina, who could tell you more about our program.
Good evening. My name is Karina Zapag, and I'm one of the mental health supervisors for the jail, for both jails, actually. And I usually work with people who are about to be released, and I do the release plans with seriously mentally ill and the mentally ill population of the jail. Okay. So we have an intake process, and as Mike said, everyone who comes into the jail is assessed by a nurse. And under our program, the nurse assesses for mental health or substance use issues, problems, and so they do a screening. And then the FMH team, the forensic mental health team, will receive all these names on a list that we have on our electronic records, and we will do another assessment that is more in-depth. And this assessment will determine if the person needs a referral to a psychiatrist, if we need to activate a suicide prevention protocol. We will also decide if the person needs mental health follow-up and how often. And we also will screen for any need that the person has for connection with outside providers, if they are going to a certain clinic or having a certain type of treatment. And also we will assess for symptoms and level of functioning. So that will, when we have a general picture of the needs of a person, if we need to communicate with medical or substance use, and sometimes the sheriff, we will do that to provide the incarcerated person with the right housing place or the right services. Next, I don't know who's, next please. So after the intake, most people will go into GP, general population, but before that, the assessment is done to see if the person needs mental health services or they need other FMH services that we have. ASU is it's a unit that we have in collaboration with a contract service, and the people who need to be 5150 or to be treated psychiatrically, they go there. They have psych interventions for people who want to go there voluntarily or involuntarily. And then we also have a unit that's called the Behavioral Health Unit, or BHU, and that's where people who, I'm going to explain later, but basically it's a unit for people who have serious mental illness, and they receive extra services because the whole unit is targeted to help them stabilize psychiatrically. Thank you. So our services for forensic mental health, we deal with crisis. We intervene every time a person has a crisis due to a mental health issue or diagnosis. Psychiatric services and medication management, we have a team of psychiatrists in the jail, in both jails actually, and people do follow-ups with doctors. Sometimes we refer our patients to the psychiatrist, and they will have a psychiatric regime. Mental health, we do mental health welfare checks. We establish every time we encounter an IP, we assess for how many times do they need to be seen. Some people need to be seen daily. Some people we see weekly or monthly or PRN, right? So we do an assessment every time we see an incarcerated person. We do a PRIA follow-up process to assess for retaliation. PRIA is the prison retaliation, prison rape, it's
Prison Rape
yes.
Elimination Act. Yeah.
Okay, thank you. So, Elimination Act. So when someone brings up an issue that it becomes a PRIA issue because maybe they've been sexually harassed or sexually molested, or mental health will do the follow-up to make sure that they are how they're doing, and to make sure that there is no retaliation from peers or from staff. We work on continuity of care. We try to talk to IPs providers in the community to make sure that we are providing them with the same care that they had outside. We also do linkage to outside providers. Some people get into different treatments while they are incarcerated, and they need to follow up when they're outside, and so we will link people to community services. We provide reentry services and release planning in coordination with mental health courts. One of the courts is 1370, and another court that we work with is the mental health division. Next, thank you. As I mentioned, we have a behavioral health unit, and this is a specific unit for to house the seriously mentally ill. We work in combination with medical, psychiatry, pod officers, and the officers are experienced. They receive specific training to work with the mentally ill, and also I think all of this sheriff people that I talk to, they want to work there. The IPs that go to the BHU have psychiatric problems, and they have an impaired psychological functioning. Sometimes they are not well to be in general population, and they need another type of milieu, another type of services. And so the services are given sometimes one-to-one. They do have groups that they can participate in. They don't have to participate, but they're encouraged daily by clinicians that work specifically there. And there is also a psychiatric nurse who works with them. So people who get into the BHU unit, they have a treatment plan and they have goals. And every time they achieve a goal, they're given things like commissary types of rewards, let's say, for them to encourage to continue working on their goals. Next one. So the criteria to get into this unit is that you have to have you have to be seriously mentally ill, have a diagnosis for SMI. Also, a lot of the people who are incompetent to stand trial get into the BHU. You have to have a desire to participate in groups and to just be able to work with others. If not, just a lot of people get in there. They don't necessarily participate from the first day, but after they know the structure and they know the deputies and the clinicians, most of them start participating with others and with services that we offer. And the IP will meet with a therapist, a medical provider, and custody to determine who is well fit to go into the BHU. And this is done in a multidisciplinary committee of people. Whenever they get in, it's a decision of different people, clinicians, medical providers, and also people from the sheriff. And the clinician's role for the behavioral health unit is there is a collaboration with classification to make sure that the person fits the criteria to get in. The clinician also provides one-on-one therapy, group therapy. They assist with any crisis that happens in the pod. They offer reentry services and the case management, and they collaborate with community providers. They also get in touch with community providers, so the people in the BHU have a good release plans when they get out, and they help facilitate interdisciplinary advocacy. Right. Our FMH team works also in collaboration with the ASU, which is the Acute Stabilization Unit, where people need involuntary treatment. ASU is also open for voluntary treatment, but they give priority to people who need involuntary treatment. They have 10 beds, and we work together with them because usually it's us who will, mental health, FMH is the team that will refer people to the ASU. And so all the interventions at the ASU have the goal of achieving psychiatric stability. Next one. We also work in collaboration with EASE, which is the Early Access and Stabilization Services for inmates who are incompetent to stand trial. And these IPs have been committed to the state hospital, but the EASE team will work with them in order to engage them and hopefully provide psychiatric treatment. And so they will also provide with competency restoration services. So people, not everybody will have to go to the hospital. Some people will have a more management of their symptoms when they get into treatment, and they would also have an education of how the courts and the legal system work, so they can advocate for themselves and with their lawyers. And so the goal for this team is that they don't have to wait until they go to the hospital and then come back. Some of the services can be provided by this team, and so people can continue hopefully with their legal process and without having to go to the state hospital. The reentry services, as Melissa said, our team deals with a lot of the reentry services for people who are mentally ill. And so we connect them to mental health clinics, socialization, rehab, mental health programs, full service partnerships, community outreach, and case managers. There's a lot in these connections, a lot of paperwork is involved. Also, a lot of meetings with the patient needed, because we need to know how they function. We need to know, if can they have medications on their own. For some programs, we'll ask a lot of questions about, can they, do they remember to take medication? Are they able to handle money on their own? So we really need to get to know them and do all the paperwork needed for them to go to places in the community. And upon release, all IPs get medications or a prescription of the medications that they were in while they were incarcerated. So they can have some time until they make an appointment with a psychiatrist if we couldn't do that when they were in jail. Next. So we also coordinate releases with the courts. I actually go to the 1370 courts, and it's an effort and collaboration with the mental health court judge, the DA, the private defender program, behavioral health, and the sheriff's office, and when available and possible with the family of the incarcerated person. And so because we feel that this population is one of the most vulnerable population we have in the jail, and so we try to really have a good plan in place where, the judge will help with the release date. So if the person doesn't have a plan to be released tomorrow because it's Friday or it's Saturday, they will have maybe a better plan to be released on Monday, a plan that is safe. We can coordinate that with the courts. Next, please. And so the other release planning that we do is with the mental health diversion court. Mental health diversion is a specific court where people who participate there have to have a mental health diagnosis, and the diagnosis have to be somehow related to the offense that they allegedly have committed. And so once they qualify for the mental health diversion court, we help with release plans too. We work really close to the social workers that work with the private defender's office, who they will do the treatment plan, but then we will need to do the paperwork a lot of times to connect the IPs to the treatment plan that they have agreed to do. Okay, so now Holvis is going to present on the SUD treatment program.
Yes. Good evening, everybody. My name is Holvis Delgadillo. I'm the SUD supervisor for San Mateo County Jails. I'm going to share some information. This program started in conjunction with the Sheriff's Office. Please, next slide. It's a new program. We are 20 months old. This program is holistic, visionary, innovative, inclusive, and it is built on the feedback of the incarcerated people. Next, please. The components of the SUD program is the Medical Observation Unit, or withdrawal pod. We have the Medication Assisted Treatment, MIT, group programming, one-on-one therapy, life skill, and reentry planning. Next slide, please. All right, so it's kind of the same process that we get. Everybody go through the intake, assess for medical, mental, or substance use. If you are under influence, they go to the medical observation unit, where in conjunction with the medical team, we medically monitor them, the incarcerated people. We assess the cause of CWA. We basically is a tool to assess how intoxicated a person is. Based on how high of the score, we need to provide more care of the individual. Vital signs are assessed, and also if an incarcerated person has the need to provide some medication, we'll provide palliative care in the area. Our goal basically is to move them to the SUD. So during the MOU part, we also assess the incarcerated person is the one to participate in the MAT program. We offer one-on-one intervention very quickly. If they agree, we provide the medication-assisted treatment. We lead them to the doctor, and the medication is provided. Again, when they reach the SUD part, we continue there in one-on-one counseling, group counseling, life skill, ASAM, and referrals to different programs outside the jail. Next slide, please. The medical observation unit, next. So it's have been beneficial for all the individuals working in the jails and the different agencies, the incarcerated person. So we all have benefit to have this setting there. Incarcerated person, the benefit has been the reduced overdose. We are providing hydration, giving more water, giving the Gatorade. They're going through withdrawal, so we have to be there for them at all time. There is an opportunity for them because they are withdrawing, they are sleepy, sometimes they lack of sleep, so there's an opportunity for them to rest and, withdrawing for something, sleeping increase. At that time, we also offer the reentry process before they go to a general population or before they get released from the court. Custody also have benefit to start these programs. It has reduced the transport of incarcerated person to the hospital because they are detoxing. Not anymore. We have a site that they can do it in the jail. Reduce medical disruption in the path. Reduce the version of Suboxone. The medical team also benefit because we have a dedicated team to the area. We have doctor can visit them. Nurses 2 or 3 times a day assess for vital signs, provide medication administration. And we also have FMH staff on site assessing them and checking on the individual where they are incarcerated there. Next. The average we have coming into these units are 8. Numbers tend to fluctuate higher on the weekends, lower in the middle of the week, but overall, 50 incarcerated people under the influence of any substance are placed in this area. Okay, next. Medication-assisted treatment. This is the path a person who wishes to participate in the MAT goes through from day 1 to day 30. Day 1 to 3 days, 0 to 3 days, they go to withdrawal management. We provide, again, fluids, hydration, help them to sleep, provide MAT education. In some cases, we induct or provide medication right there on site. Sometimes it stands a little longer based on the individual, okay? Next slide, please. Next. Okay, so this is the overall of the program of SUD part. This is the supporting. We use modalities that helps. They are evidence-based treatments. They have proved to reduce recidivism, overdose, and reduce the criminogenic thinking. The modality that we use start now. The metrics logic model in English and Spanish, seeking safety, metrics model for criminal justice setting, motivational interviewing, and recently, on request for the female population, we created a new curriculum specifically for the female population. Next slide, please. So is the program working? So what we did, we came up with the concept to provide a survey and divided in 4 sections, and 200 IP have participated in the survey so far, and this is their average, the percentage rate they have graded us. Program satisfaction, there are 6 or 7 questions in regards to the area, the skills of the counselor, the program structure, whether you like it or not, personal skill development, you benefit from this. Those are the average that you gave us, the percentage. And the program is new. We are adapt to the situation. We adapt to the feedback from the incarcerated person. We adapt to the feedback from the staff. So the program will continue moving and continue we adapting to the needs outside in the community. So we're trying to emulate something that outside and emulate it in the correction setting because it's very an unorthodox place to provide the kind of services. Next slide, please. So successes, we have been able to reduce overdose in the jails. We expanded significantly the SUD program. The program before, we had something not exclusive for SUD, but the numbers of individual participants was limited. So far, just in this year, 550 individuals have participated. We were able to open the medical observation unit before all the people who were withdrawing were displaced everywhere in the jail. Now having them in one setting has really benefited all of us. We have increased the referral collaboration with the Sheriff's Office, specialty courts, behavioral health, and CVOs. We had reversed 10 overdose this year, reversed using Narcan. We have a kiosk in the medical observation unit that basically is a place where it's a kiosk, it's a computer where there are incarcerated person can go and look where are places they can go for services outside. If we don't get access to them, they can do it on their own. They just click on the touch a map, the computer, this monitor, and they can click and it will get information about the address, telephone number, and how to get there. Okay, that's part of the kiosk and the benefit. We also have a Narcan vending machine in collaboration with the Sheriff's Office and CHS. We all have this machine. It's located in the lobby. It benefits every resident of San Mateo County. Anyone can go and get their own Narcans, as many that they want to. Okay. We also are including Narcat in the path. So basically, is in certain parts of the jail we have Narcan. Anyone can use Narcan if somebody is overdosing. Part of this pilot is we also are educating the incarcerated person how to use Narcan. And so far it's working, now we haven't heard any complaints. Next slide. Okay, this one will be Mike.
I'll take this last slide here just to show you some numbers that of who we serve and how much it costs the county. So on our monthly average, we see about 300 patients on sick call. That's MD or NP. Usually it's a lot more. And then number of RN sick calls. Those are, we average about 900 or so every month. And that's from this request from patients requesting services through medical. Either they submit their request in paper by notifying custody or submitting it through their smart communications tablet. 175, those are new patients that we see on a monthly basis that are now engaged in SUD. Those are identified, so every month as we screen them, this, it just adds up. And of those, 30 are receiving MAT services. And just a good number to realize is like, how sick our population is, the number that comes in. 41% of our new patients have either mental health disorder or a substance use disorder issue. So that's quite a big number, and that's the population that we typically see. Costs on the right, it's $258,000 every month spent on pharmacy. We are a net county cost, so all that we provide is absorbed by the county, and that's gone up by about 10% since the last calendar year. 37% of our pharmacy bill is now related to SUD treatment, and of that, like $97,000 every month is to the injection that we provide for MAT services, for MAT treatment. That's Sublocade. It's a pricey medication. We do take advantage of a state pharmacy distribution program where we're able to get discounted pricing on some medications, but it's still pretty expensive. And about $22,000 of our monthly bill is spent on just long-term injectables of psychiatric medications. So just to give you an idea of what our costs are. All right, and I think that's it for our slides. Thanks so much, and we're welcome to answer any of your questions.
Yes, thank you all so much. Okay, opening up for questions from the group. Rob, and then Bill, and then Rebecca. Yeah.
Thank you for the info. How many, with staffing in your unit, how many full-time doctors, nurses, or do you have in your staff?
Sure. For doctors, we do have a contract with Vituity. They're the same medical provider that supports our San Mateo ER, emergency room. So they provide us with at least 30 hours of coverage every week. And nurse practitioners are our main source of sick calls and who sees majority of our patients. We have 4 full-time and 2 extra help, and another extra help for midwife.
You mentioned doctor. Is a doctor on site?
Doctors on site at least 3 days a week at each facility, but nurse practitioners are on site at least 5 days a week. But nurses are in the facility 24/7. RNs, registered nurses.
So a doctor isn't on site like 24/7?
No.
In the facility?
That's correct, yes.
Okay, thank you.
Yeah, thank you for the information. A lot of information, but really good. How large is the behavioral health unit?
We have 2, one for women, one for men.
Do you want to just? Do you guys want to take the extra microphone? Yeah.
So we have one whole unit for the men. Right now we have about
49.
49.
49 as of this afternoon.
Yes. And then the women is smaller because we have less women incarcerated. And today was about 18 or 18 we have today.
Are they, do you ever have demand that exceeds the size? And what do you do in those circumstances?
Sometimes we do, yes. What we do is we assess the person and then we work with them closely, and when a space opens up, we'll move them into the pod. But their clinicians who work in the behavioral health unit will connect to these IPs more often just to see how they're doing and to assess them to come into the BHU as soon as possible. Yes.
Great, thank you.
I just want to add though, aside from the doctors, we do have psychiatrists also full-time, 2 full-time psychiatrists on duty.
Michael, thank you. I'm really interested in your unit. So I have 3 questions.
Of course.
So the first one is, you mentioned that most are in poor health, and I wanted if you could just give an idea of what are some of the conditions that you're needing to address, as they're doing the assessments.
So a lot of times, most of our patients come in, without doing their their routine care, right? You have your hypertension patients that don't take their medications, diabetics that are poorly controlled. Their numbers are so high. So we have to manage them more frequently and see them. So we establish those care early on, and of course, our mentally ill patients that come in without meds. So we have to start them on medication. So those are really the big challenges that we have. We try our best to get them to where they're at. So when we release them to the community, they're better off. So we get them worse off. We take care of them. We provide them with discharge medications, hoping to connect them to our county resources upon release so they could follow up. Because that's our goal, just to make sure that we have a full continuum of care.
Thank you. So the other question I have is, can you give an idea how many incidents of injuries while incarcerated? Like how many times are you seeing people that they come to you because they've been injured while they're incarcerated?
Oh, so for patients that have been injured? I don't have that data, so there's a couple ways to track or we see those. So those coming in from the streets, coming to us with injuries, I don't have the exact numbers, but they're frequent. That's why part of our job is to screen them for any trauma-related injuries aside from their medical issues. Want to make sure they're okay. They didn't have broken bones, they get in a fight with the police, or out there in the field. We want to address those. So we see a fair amount number of that. We book about 35 patients, see 35 patients every day. I can't really give you an estimate of how many might have some sort of injuries, but we do see them. And our process is that if they do have some sort of injuries that we want to make sure are addressed early on, we refuse them from our intake area, send them to the hospital to get the initial evaluation, and then we receive them, and then we do the follow-up care.
And then
But-
what about injuries while they're actually incarcerated?
Not that often. A lot of times, if there's injuries, it's going to be an incarcerated person versus an incarcerated person, like fights between
Right.
individuals, and we will see the combatants and treat them. It's not that often that we see any injuries, or that's related to something else. I mean, for staff, definitely, we don't worry about like safety for our staff. At least I'm not worried about it for our safety.
Yeah,
right?
yeah. Okay, thanks. And then the third question
Sure.
is just, it sounds like you're the manager or the program director?
Yes, I'm the
for
director
health-
for the whole of Correctional Health,
Yeah.
yes.
So what would you say are your most urgent needs?
It always comes down to staffing, right?
Yeah.
So as we try to provide all the services that we need, or at least we hope to provide, it takes manpower. And, that's something we hope to, improve upon. And I think, we're working with the county executive's office. We're able to slowly accomplish that, especially with this recent budget cycle. We gained some positions. We gained a nurse practitioner. We gained some full-time nurse RNs and LVNs that provide medication. But of course, CalAIM, I mentioned earlier, it's a new initiative where we have to provide those services for reentry upon release. And that takes a lot of extra staff as well, because now we have to see everybody, provide the same level of service, connect them to all services, out of county or in county residents. We have to see them and provide for their care. And of course, that takes time and a lot of manpower. The state is giving us some money, startup funds, but it's not long-term, so we have to absorb some of those costs. But what we're hoping for is that the reimbursement dollars that we'll get out of Medi-Cal in the future, we could roll back into our system and help provide for the patient care.
Go ahead, Alexis.
Thank you so much for your presentation. I have a couple of questions.
Sure.
A few of my questions were already answered.
Okay.
One of them is during the intake. So in my visual process, it's based on Law and Order or some of the cop shows. You get arrested, you're in the cop car, you get to the facility, you're handcuffed and you go in. And you're saying that you see them in medical first before they get fingerprinted, before they get mugshots, all of that.
Yes.
Okay. Thank you.
But there's a but though. I mean, it's not like what you see on TV.
Yeah, so that's the only thing I had to
Yeah,
rely
okay,
on,
yes.
was what was on TV. So I was trying to understand where the
And I'll
medical
explain that.
part
Sure.
came in. So what is the purpose for knowing if someone has insurance or not? That was in one of your...
Oh, of course, yes. So we are tracking insurance information because of their efforts to advance CalAIM, that initiative by the state, where we're able to bill Medi-Cal for those eligible patients. So if they don't have insurance, then our team will help insure them and help get them eligibilized. So we could take advantage of Medi-Cal reimbursement if they meet certain criteria.
Okay.
But in terms of, just go back to your about the handcuff stuff. So
Yeah.
the process works by, so as they come in, they get searched by our sheriff's office personnel, and then they're out of handcuffs, and then they sit in front of the nurse, and we do a full intake at that
Okay,
time.
all right, thank you. Final question.
Mhm.
So health maintenance is on-site 24/7, is that correct?
Yep, 24/7, nursing is available in all facilities.
Okay,
Except the juvenile facility.
Thank you.
Any other questions? Go ahead, James, and then Shirley.
Thank you. Thank you so much for all the information, a lot of stuff. Just want to talk a little bit about the substance use disorder stuff. You talked about 550 IPs utilized the services, and then I see something but 175. So I'm trying to understand, when someone comes in day one and maybe under the influence, is that what you're talking about, the 175 new IPs? Or can that be a new IP at any given time of their stay?
It can be any given. It can be anyone, yes.
Okay.
Yes.
Thank you.
So I'm kind of interested in when you started the substance abuse or substance use disorder program and its relationship to, we had 2 overdoses within the last year. Was your program after that, or, could you kind of clarify that?
Hold on one second. Is it a?
Oh, no, that's fine. I was just making sure you guys spoke into the mic when you were
Okay.
talking
Oh,
back
Okay,
and forth.
because I was
Yeah,
like, anytime I
thanks.
see them.
Yeah, thank you, though. Thank you, though. Yeah.
So we've had 2 deaths in our facility that are related to overdose, is your question, right? So one of them from last year, 2023, early on, around January, and that patient came in from the streets, a new booking, and she had something inside that caused the injury. So she was, it was in her cavity. So, and she had cleared, she was cleared at the hospital prior to coming to our facility. So that was an unfortunate event. It's nothing we could prevent or really know that it's there because it was packed inside. The second one, as a recent incident, I really can't comment in terms of like the specifics of that. But I believe the way our medical observation unit now is set up, it wasn't at that time. Yes, it was a different program. Now it's more, it's much better. And that's what we do when we do have deaths, is we look at our process to see where we could make improvements. I know that's a big concern. I mean, no deaths is acceptable to us. And our numbers have shown that we're like really probably second lowest in the state of number of deaths. I look at our deaths, said no deaths acceptable. We've had some years when we haven't had any death in our facility. 2016, 2018, 2021, no deaths at all. Since 2012, we've had 18 deaths in the whole, this whole time. So can we prevent some of them? We hope we could, and we could have made some difference, but some are natural causes. So that's hard to prevent, and that's why we try to, see them more often, offer the services, and provide, specialty care, and do all those things. And now, as part of when we have deaths, we do death reviews. We follow the National Commission on Correctional Health Care Standards in terms of trying to figure out what's the best way to, address those things moving forward. How can we get better? What can we do next time? Are we following all our policies? I mean, is there any gaps in services? So we look at all those. We do a clinical mortality review, administrative review, psychological autopsy. We do all those things just to learn from that experience so we could prevent further injuries or death. So we look at all those processes.
Thank you all so much for the time you spent here and the work that you're doing. It's very informative. I have just a couple of questions. I know we talked about staffing. Can we also talk about the mental health staffing? Because I know that's incredibly hard everywhere. And so can you talk a little bit about the ability to meet the need and the gaps?
Yeah, so we are staffed from 7 a.m. to 8 p.m. every day. After-hour support is available. We have on-call psychology or a mental health team, supervisors typically, that's available for consultation. Our nurses are trained also to help support and identify mental health conditions. As a fallback, we always call the psych emergency at the hospital at San Mateo Medical Center and consult with them. We do have policies in place where if someone's having crisis, we have steps to, mitigate that and how we can address that, provide the medication, time to get better, and definitely to make sure that they're okay. And we definitely follow up on them.
is there a referral process? I know there's the original intake, but if someone is okay when they're intake, but then start to have mental health issues while they're incarcerated, what does that process look like?
Sure, it's actually, it's a good process because, there's multiple ways to access services. As I mentioned earlier, the patients can request services directly, either by submitting a paper form, electronic version. They tell the pod officers, and they call us. A lot of times, sometimes it's the pod officers on duty that will see, hey, maybe someone's not doing too well, or they came back from court, maybe getting some bad news. So they would alert us and let us know that there's something maybe possibly could be an issue, and we help, try to get them seen right away and address those things.
And then your ability is to have speakers on other languages. Do you have enough staff to cover that?
Yes, we have a very diverse staff, speaks multiple languages. We take advantage of the translation services that's offered to county, in our county. So if there's any, issues that there's someone that speaks that language, we connect with them. Also availability for ASL, to provide that sign language through telehealth visits, so we could make sure that they're taken care of.
And then one-to-one visits, those are in person?
Yes.
Yeah, okay.
Yeah, we only do in-person visits.
Only do in person?
Only
In person, yes.
Okay. Those are all the questions Does anyone else have any questions?
I just wanted to echo your thanks to everybody for spending the evening. It's very informative, I thought, and also I hope will really enrich the experience or bring a little more understanding to the experience when you all go on all your jail visits. So you'll have some ideas about what's happening, and it won't all be so new. So thank you to all the commissioners as well.
Yeah. Thank you.
Okay, thank you.
Thank you.
We'll let you go home. I know you're there. Thank you so much. Okay, so now moving on to our public comments. Turning it over to our clerk.
Thank you. Members of the public, if you wish to comment on agenda item number 4, please use the raise hand feature on Zoom or bring a speaker slip up to the clerk during this time. You will be granted 2 minutes to speak at the time your name is called. We do have one hand raised on Zoom. We do not have any speaker slips. I would like to begin with caller ending in 562. You may begin when you are ready.
Good evening. Thank you very much. Thank you very much for all your questions. There's so much that I would like to address. Let me emphasize, you heard the presentation from people who have a job in there. There is a huge disconnect between the reality and what is offered. I have not personally been involved in incarcerated persons, but I have been in vulnerable populations, assisted living, the elderly, and the very young, in people who are they might be undocumented immigrants in the school district. So yes, they will protect everything to protect their policies and their programs. But you need to hear from the people who are in there. Remember, there's so many professionals that they have to abide by. Once you're in that, you have no rights. They will say you have rights, but your destiny is determined by those professionals. And I would like you to understand, you need to hear from the families. You need to hear if this is really true, what you heard today. I'm very upset because what we heard, and I hope you heard that quote, the goal is to give them the quality of healthcare that is greater than is available for the general population. And that is true. It's not fair. So, I'm sorry, but you have to have more data. And in most cases, you will not receive the data because they will say this is a violation of civil rights, of personal rights, of privacy rights, whatever. It's not right. We need to have a full understanding of what the systemic issues are in everything from healthcare
Thank you. I'm
to
sorry,
education
that's
to
time.
this. Thank you.
Thank you. Last call for public comment. We do not have any other public comment.
All right, moving on. If there's any commissioner or liaison announcements or things you want to share before we break and go home. Go ahead, Shirley.
Sorry. I would just like us to have a few of kind of administrative procedures. And one would be if we could have minutes for each meeting so that, and that they would be done within a week of our meeting so that we would have a chance to review them and so that we could approve them at our following meeting. That's one thing. And then another suggestion is, and I think it's been brought up earlier, to have a website that has, last week David did a great presentation with a PowerPoint, and Melissa's was very good in the health department. It would be useful for us to have the PowerPoints and just in one spot.
I think they are on the website. Emma can confirm.
Yeah,
Then
I
I'm
saw
looking
the
at the wrong place.
presentation for tonight. There was a presentation that was available that I clicked on and looked at this afternoon.
This afternoon?
Yeah.
Okay. I'm amiss on that one. Okay, great. And then the last was if we could just have sort of an action item spreadsheet, because I think there's been a lot of really good comments, both from the public and around this table, and they're kind of getting lost because we're getting so much stuff thrown at us. And it would just be where it just be a spreadsheet with the action item and then, person responsible and if it gets completed or not.
Yeah, that's a great idea. I think staff is keeping a spreadsheet of the action items and different items. And I think the intent on the ones that we can't take care of immediately, I think there were some that were asked and that we took care of. I'm not springing to mind right now. But the intent was to bring those to the retreat in part and include them in the overall discussion. But they're keeping close track of the issues that are raised. And then subsequent to the meetings, we're having internal meetings, including with Supervisor Slocum and staff or liaisons to identify some of the issues that have come up and start strategizing and having those available for the retreat.
Thank you.
Yep, thank you.
And then I just also want to say that while the list will be great, I just want to be realistic about what we're going to all be able to do. Right? So, how many things on the action item list, plus the list that we're looking at to prioritize between all of us, are we going to be able to tackle? And so that's what I'm thinking about, because, what I'm hoping to come out of this is that when we go in the retreat, we pick 3, maybe 4. I wouldn't pick more than 4 things that we want to have a deeper dive and look into. So and then that will be breaking up into that many teams. Maybe some of us could be on multiple teams, but we all have full-time job. Well, I don't know. I think, I have a full-time job. I have 3. How much time are we going to, I want to be able to devote a lot of time to that. And then being realistic about our capacity to also tackle things on a running action list, so just being realistic about what we can do and giving them enough time for us so that we can properly do the due diligence so that when we make recommendations, we have full buy-in and they're moved forward on. Go ahead.
Yeah, I appreciate about the time, but I'm also concerned that the important discussions that happen here get documented. And so I'm appreciating the minutes, that there need to be minutes, and I think there needs to be a staff person who does that. And then we approve of the minutes. And I wasn't really clear on which part you thought was going to be too much. It's setting the agenda, or?
No, I'm talking about the staff are keeping a list of anytime they're hearing something that's in public comment.
Mm-hmm.
They're keeping track of those different things. But but I am also listening to all the things that are being presented, and in my head already thinking about what are the things that I would like to prioritize for us to look further into. And so while we're gonna have an action list that's gonna have a whole bunch of things on it, and then we're also gonna have the 2 to 3 or 4 things that we decide to look further into, being realistic about how much can we tackle and pay attention to an ongoing active list and be able to do the work that needs to get done to do research, ask questions, interview a variety of different folks, put together a presentation and have it ready to present to the Board of Soups, all of us at the same time. So just being realistic about that. And then also just thinking about none of these problems were created, a few months ago. We're not going to solve them in a few months. So what do we have the capacity to do well? Go ahead, Alexis.
I agree with you, Kalima. We have to have a small list of action items. And then regarding the minutes, this is only my 3rd meeting, but I do believe all the meetings have been about onboarding. So it hasn't been a lot of to-dos for the actual commission. So the purpose of minutes would just repeat what the onboarding was. And then if they're keeping a list of the comments from public, and maybe our comments also, we'll have that. So I don't see minutes being needed right now, but once we have our commission set up and Kalima's running the meeting, setting the agenda, you and the co-chair, Bill, maybe minutes would be needed at that time. But what are we going to repeat in the minutes, the entire onboarding presentation?
Yeah,
That's just my
I can indicate for most of our commissions, the minutes are usually very short, just descriptions of the action taken, and we usually refer to check out the videotape, because now we have the full videotape of everything that's there. So we don't usually have like the lengthy this person said that person said this type of minutes for our commissions any longer. Yeah. But thank you for the comments. I don't mean to say they're all taken care of or whatever. I appreciate you sharing the comments and whatnot.
I'd just like to clarify what I meant, and I understand. I don't want to hear everything that was thrown at us. But, for example, when we talked about the voting, and we went through a long presentation, I don't want anything on that. What I want was, like, the sheriff said that, people are going to be registered to vote. So we had asked that she give us the number of people that were registered and how many people voted in the jail after the election. That to me would be really nice to have in the minutes and on the action sheet, so that, because we're going to forget about it after the election probably, and it'd be really good to know.
Fair point. Yeah.
This thing's so hot. Will we talk about that? Because I think, one of the things, especially when we go on a retreat, we're talking about getting on the same page. I think that was one of the things we talked about, was common language. But I think we're all at this table and abroad not understanding just what minutes look like. So we're all coming to the table with something different.
Yeah, I think
because we are voting on minutes, but I'm looking and I haven't looked at a minute, but I said yay.
Yeah, that's a good point. We can just maybe next time or at one of our upcoming meetings, we can show a little bit what our typical minutes look like.
I
for
think
the
they're
boards
just going
and
to pull some up
commissions.
really quick from
And-
another commission, maybe, so we, oh, no, these are minutes. Oh, no. Okay.
This is an example of what it would look like. And I just want to clarify on the list that we're capturing, they're not actionable where it says who's responsible for what. We're capturing what you're saying. There hasn't been an assignment to say staff do this, but we are capturing as much as we can from not only public comments, but what's taking place here. So we are keeping that running list because we think it's going to be very important when you do your retreat as well as there's some things that we're able to do really quickly in the back end. And an example is the very first meeting, there was a lot of questions about elections. We put that, and this is before there was a chair and a vice chair, we brought that forward and had that presentation. So we are actively listening, trying to make those changes in the back end as much as we can as well.
Is there a way that we can, or just the commissioners have access to, like, can it be a Google Doc?
Yeah,
It has to be public on the website, okay.
a Google Doc of that, the running tally.
Of the running list.
Running list. Yeah, let us talk about it with council and see how that would work in a
Okay.
Brown Act compliant way and whatnot.
Even if it isn't a Google Doc, if we could get a running list so that we and the public are aware kind of what that list is, the comments that have been heard, and that might then also frame, be a good document to bring forward to the retreat, is here's the list of all these comments and things, but let people see, and then if we see it and there are things that are missing that we've heard that maybe aren't picked up on the list, then at the next meeting, we can say, hey, this was another comment, something like that.
Would it be helpful if we perhaps, we'll talk to county attorney's office, but on the November 6th or the 16th, we can put that agenda item, we can bring that list, and then you guys could identify if there's anything missing.
We'll work we'll work with the chair and the vice chair to come up with a process to capture
If it's
these
not
things.
something that we can edit, it shouldn't be a problem for us to all see it.
Right.
Because it's just us reading it, and it's just to make sure that Shirley, like, the point that Shirley made, that the things that we're asking for are captured. So, if you want to make it available to the public, that's fine too, but I'm thinking just so we can see it, just so we can make sure everything's on it that we think should be on there. Is that, I don't know.
Generally, if we see it, the public has to see it. So,
Okay.
So
Yeah,
that's why
yeah.
So I think putting it, just adding it as an information item, or
Mhm.
maybe it's a discussion item to say, here's the current ongoing list. Does the commission or the public have any other items that people think have been stated that should be added to the list?
Fair enough. Okay.
Okay, cool.
And maybe that's every meeting. I mean, maybe that's just an ongoing list that is an agenda item at every meeting, and then things can be added to it.
Yeah, an agenda item or attached to the minutes of every meeting, and
Yeah.
that way it's public.
Okay.
Yeah, and then I do agree that we should have the minutes, even though no action may have been taken for these other meetings, and that the minutes should be approved by the commission.
Yeah.
Yes, and we will work on that.
And I know it takes time, so.
We will definitely work on that. We're just on a very fast, accelerated pace, and we
I know.
normally allow 30 days for us to do that, so I will definitely get those.
Been
to the
there,
group.
done that, understand that.
All right, anything else? No, all right. Oh, sorry, go ahead.
That's okay. How's it turn on?
I think it's
up on the.
I think his may be different.
I think this is different.
It is on, it's on, yeah.
Is it on?
Yeah.
Okay, great. So I don't know if Stanley or Michael are on the Zoom call. If they are, they could answer any questions. But I thought what I would do is give you a little bit of an overview of what the last, the June 17th meeting was for the CARE program. And in essence, the cadence is very different between this meeting and that meeting. The CARE program is meeting quarterly, so there won't be an update every single time. I didn't want you to think we just sat in the background and did nothing, but So basically, the topic area was the collaboration and information sharing across the different sheriff offices, and there were 80 fusion centers throughout the United States, and the goal of the fusion centers are information sharing, maximizing any resources associated with information, or streamlining operations for improved, crime fighting. And in essence, the presentation centered on the fact that there really is a need to facilitate information sharing for suspicious activity reports and things of that nature. So the last thing I can share very quickly is that the major area of focus are human trafficking, ghost guns, including printer capability to make ghost guns, drug trafficking, and then, of course, things like terrorism across the United States. So that was the area of topic.
I think is
George, anything to add?
somebody's, yeah, Mike's on the Zoom.
Yes, I raised my hand too. Yeah, this is Mike Klobuchar. I'm also a CARES liaison. Our last meeting was actually last week, and we talked about and gave an update because Stanley and myself are on this. So we gave an update on the independent commission and where we were and what our plans were going forward. We talked about the voter registration of incarcerated persons, physical mail in the jails, the addition of 110 new hires, and the situation that's been in the paper in regards to overtime added to the correctional facilities. So I want to give that update.
Thank you so much. Thank
No
you,
problem.
guys. All right, anything else from anybody? Nope, okay, and motion to adjourn?
So moved.
We're adjourned, thank you so much.